Hi, James. So we are ready to go. So
Okay.
uh, let me introduce Dr. James Laba. He's a fellow of Royal Australian and New Zealand College of Psychiatrists. He has done his MBBS from the University of New South Wales, and he was a senior adjunct professor at the University of Monash, currently joining in from Melbourne, Australia. And we are having this academic guest lecture. Uh, the screen is being projected here, and for the residents of Department of Psychiatry at PDU Medical College, Rajkot.
Fantastic.
Okay, James.
Yes, thank you for the introduction, Divyam. And thank you for the whole team and Professor Chandrani for organising this. I'd like to keep this as informal as possible. So I will be taking some questions from the floor as we go along. We'll just have to monitor that and see how it works. So we're talking about advanced perspectives in bipolar disorder with a tagline of Tangled Up in Blue, a psychiatrist's insights with lived experience. And our sponsors are there, Concern. And I'd like everyone to appreciate that clinical illness can be inferred from ordinary and sometimes evolutionary processes. I like to draw an arc between evolution, affiliation, power, and a thing called reverted escape. They're the three things I'd like you to learn, and really not much else. From the perspectives of evolutionary theory, neuroscience, and dynamical systems, or chaos, will be the perspectives that I take. And I'd like to locate the illness in two places, in the Tesseract, which we'll describe soon, and in a spectrum I've called the X-polar spectrum, and I will explain that. So the core ideas are that X-polar or bipolar disorders emerge from evolutionary social dynamics involving prestige and dominance. That they are conserved defensive modules, exemplified in reverted escape, which I will describe. But in fact, modern stressors have destabilized neural timing as a consequence of this evolutionary history. And the hippocampus becomes a locus in the behavioral inhibition system network. It becomes the locus in the origin of mental illness. And I'd like to say that this has been my, I guess, my pursuit, my raison d'etre, that mental illness has meaning. It's not a meaningless thing. Now we'll talk about prestige and dominance. Prestige you may think of as belonging to movie stars and presidents, but it's not. It's just the simple process of society giving value to the individual, of cooperating, learning, and being creative. It's a process that really happened 50,000 to 12,000 years ago, when people gave way or started to do away with the agonic mode, this dominance mode of relating to each other, where you've got an alpha and you've got submissive people as well. I'd like to say that dysregulation of these systems of prestige and dominance underlies mood states. And this was a book that got me going, really, with prestige. It, by Stevens and Price from about 1998. And they said that the shift from power to attraction in evolution enabled the rise of this hedonic or prestige mode. And human, they didn't say this, but other lines of thought have suggested that humans became less robust in the Upper Paleolithic era, that they lost their robust features. They became more childlike and more gracile or thin. They self-domesticated themselves. Now, prestige in evolution is the pathway which evolution's individuals gain influence through not through dominance, but through being valued, imitated, and granted deference, because others seek their opinions and their value. Now, this is something some of you might be aware of. This is a thing called the Tesseract, which is a four-dimensional cube, a hypercube, which we'll talk about in a minute. I was inspired by a number of people to draw this. It's been quite a useful device, really, for mapping mental illness. The notion is that you have four axes based on Gray's axes of behavior activation, behavior inhibition, and social withdrawal, fight, flight, and fright. And I've added to that another axis, the rage axis, which I see as leading to mania. I believe that social approach, behavior activation leads to hypomania. Social withdrawal, fight, flight, freeze leads to melancholia. And social divergence or schizotypy on this axis here, when severe, leads to schizophrenia. And these are all sort of anchored by what I've called the facade archetype. It's just a description of people with the bipolar disorders, what they tend to have in common. This is from largely the psychiatric and psychological literature. Now, we just got mentioned that this axis of withdrawal is the depressive axis. The axis of power is the manic axis. Affiliation belongs in the hedonic or prestige mode. And social divergence, probably from my reading in its early stages, can actually be associated with creativity and novelty. But of course, when it hits a certain peak, it tends to lead to schizophrenia. So the bipolar phenotype I mentioned earlier is characterized by fear. People with bipolar disorder often are afraid. They often have anxiety. And for instance, Merrick Angus has found that something like 90% of people with bipolar disorder will at some stage have an anxiety disorder. The self-esteem is vulnerable. They tend to strive for quite extreme goals. And as you know, they're prone to addiction and depression. So one thing that Tesseract can let you do is to make us the criteria for a simulation. And this is a simulation of schizophrenia with kudos, with positive regard, and schizophrenia with stigma, which I'll show you in a minute. But in this simulation, the person makes some social success. They risk stress-triggered backslides, and so it's a trade-off for them. And with stigma, the simulation found that stigma crystallizes around the agent's episodic departures from normal behavior. Their unpredictable social flair registers as odd or threatening. They retreat into hyper schizotypal patterns. even when they're only symptomatic 2/3 of the time. So this is what you can do with this Tesseract. You can plug the numbers in and you can run a simulation on your computer. Now this is an overwhelming slide, which I'll just break down into one axis. This is what I've called the X-polar spectrum. It starts at the zero node with the prestige leader, and that is accompanied also by a group of people who are shamanic leaders, ritual specialists. And I've named the second category, the odd kid on the block, who may have a family history of bipolar disorder, but has the phenotype that is obvious, it's evident. The next category I've got, the third category, is bipolar depression, which is the simulation called this typus melancholicus. I didn't actually call it that. It made it quite obvious that's what it was. So that's people with history of depression who rely on order and structure, and when they lose the order and structure, they often settle into depression. At the fourth category here, we've got bipolar 2 disorder, and that's followed after by psychotic condition, schizoaffective disorder, which again popped up spontaneously in the simulation. And then we've got bipolar 1 disorder, which you're familiar with, in which people do develop rage and an attempt to dominate. And finally, the seventh position, we've got schizophrenia. Now, we're going to talk about 4 processes, maybe 5 processes that get a person to move up and down this X-polar spectrum. And one of which is a thing called epigenesis, where stress alters gene expression. It doesn't alter the gene, just the expression. I'm sure you're familiar with this idea. You can have DNA methylation and histone modification causing this epigenesis. And epigenesis encodes experience and stressors into ongoing biology. And it can, in some cases, even be inherited by the offspring. Usually not, but can be. An example, mechanical stress of lifting weights triggers gene expression in the muscle cells. This leads to protein synthesis and bigger, stronger muscles. So that's one way you can move up the X-polar spectrum. Just to mention, the genes have not changed. And then another concept which is useful is that of allostasis, or ability through change. Stability through change, where stress triggers changes, and you can get allostatic load, wear and tear. And an example, standing up, gravity suddenly pulls the blood pressure in your legs. Instead of letting your brain become hyperperfused, the body predictably increases heart rate and vascular tone. So having a situation there where the body's predicting change and accommodating to it, often with increased metabolic costs. So that anticipatory dynamic adjustment, stability through change. Now, the other way you can move up and down the X-polar spectrum is through opponent process. And Solomon and Corbett described this in 1974. And it's the recruitment of the opposite. So if you have an opposite syndrome like a drug euphoria, the body will be attempting to throw you into withdrawal. And similarly with a depressive episode, it's quite common to get a hypomania on improvement with that. Of course, the other thing that will cause people to move up and down the X-polar bipolar spectrum is if they get medication, ECT, or therapy. Now we're going to talk about shamanic origins of these disorders. You're probably aware that shamans lived tens of thousands of years ago, and that there are modern shamans as well in ritual positions. They're able to enter transient controlled psychosis-like states. The group supports their functioning. Back 10,000 years, 20,000 years ago, they were the meaning makers, the cohesion specialists, the threat navigators. And they may be the ancestral root of hybrid, that being psychosis plus mood phenotypes. So we've seen an evolutionary transition over the last 20,000 years. We've moved from the Stone Age, the Paleolithic, to the Neolithic, through which towns and cities formed, and society became very different. Became stratified socially, with people with a lot of wealth and power and people without much power. There was an increase in social complexity. Instead of having these clans of small egalitarian people, we saw complexity and ambiguity. We also saw stigma form. And there was a pressure on the regulation systems. On the regulation systems, which would serve people very well back in the Stone Age, but it wasn't serving them so well once the Neolithic change occurred. So we're going to talk about reverted escape. That's a notion very well known in ethology, in studying animals. It's an evolutionary module. It's conserved, and it's a feature of lots of different animals and birds and fish and humans. In reverted escape, someone tries to escape, but that they find that collapsed back into a high arousal immobility. You might see this sometimes in dissociative states. So they're caught in a simultaneous go and can't go, where the signals become jammed and conflicted. And at that time, hippocampal timing destabilizes. And this is a primate example. We've got the alpha male here and his subservient males and females. But what about this one here, this primate? Is he in or out? If he tries to escape, he'd risk injury and possibly exclusion, possibly death. So what he does is he doesn't escape. He's got this impulse to escape through threat, but he reconciles that with making himself proximal to the alpha. He reverts his escape. And you're probably wondering what that's got to do with psychiatry. That may be a crazy idea, but I'll talk about why reverted escape might matter. It's a hypothetical situation. In reverted escape, there is this distorted time, sense, and narrowed attention. The focus looks onto threat-relevant cues. You probably can imagine the primate quivering with fear, probably not looking at the alpha, but being terrified. At these times with human groups, there is a heightened meaning-making under constraint. The mind rapidly interprets cues without motor feedback, amplifying salience and a sense of imminent change. I just wonder if it sounds like anything else we see, psychosis or a dissociation. Are there any questions there?
No, we may continue, James.
Okay. I'm worried I'm going too fast. And we can talk about modern stressors that have happened on top of this evolutionary background. Social valuing can be very unstable and unpredictable in society. We may feel high self-esteem at the reception we're afforded, or our self-esteem may collapse with loss of social valuing or prestige. Another stressor is power imbalance. And when you think about it, our evolutionary forebears didn't really have much in the way of power imbalance. 50,000 to 12,000 years ago, the Upper Paleolithic was a time that the clans were egalitarian, and it became the fact that they ruled by prestige and not power. And in the modern situation, there of course is often ambiguity. What do things mean? What do I take from that? It's unpredictable. And then there's the urban environment, which increases all of these. Isolation and stigma can also occur. So think about the shaman, group number 1 in our category. He may have formed a schizoaffective ridge, a path from the ancient to the modern, a transition from small egalitarian clans into living in towns and cities. And Polomeni has talked about this, and he feels that schizophrenia may have been the precedent for shamanistic behavior, and that schizophrenia may be a vestigial remnant of that now. But he didn't look at affect as well. He looked at schizophrenia. We'll talk about hybrids. People have mixtures of affective syndrome and psychotic syndrome. And this is what I mean by the schizoaffective ridge. We have our shamans back 10, 20,000 years ago, and they were revered as spiritual and linguistic leaders, narrators of meaning, utilised reverted escape to bring meaning back from visions. But they've, of course, largely gone, largely disappeared. And perhaps, just perhaps, they've been replaced by people with schizoaffective disorder, a ridge into the present time, a ridge where you've got cliff edges into symbolic injury or psychosis, and cliff edges into prestige injury or affective disorders, cliff edges into dominance phenotypes, such as with mania. And we'll turn just briefly to the parvalbumin interneuron. It's responsible for precise GABAergic timing in the brain and for controlling neural excitation, largely affected by glutamate. And this parvalbumin interneuron is not only crucial, but it's extremely sensitive to genetic, epigenetic, and stress. And you can see it with inflammation with microglia. They will often disrupt the parvalbumin interneuron in these neural nets. They are quite vulnerable to toxins and inflammation. So we can see in reverted escape that there may be a hippocampal timing breakdown. And this is the case in psychosis. The theta rhythm, which the hippocampus produces, is not coupled properly with the brain gamma rhythm. The context of the perception is not bound properly. There is a blending of content, motive, intention, and perception. And may this be the final common pathway to psychosis? I'd like you to think about that. And we'll talk about X-polar 3, bipolar depression. As you know, it's an impairment of connection with the tribe, but both back then and now. It reflected in rejection sensitivity. My study found this in bipolar 1, 2, and bipolar 3. People all had this sensitivity to rejection. So it looks like the bipolar depression is different from unipolar depression, and possibly only with this difference, the rejection sensitivity. I think they tend to get more atypical depression too. So when someone has a bipolar depression, what do? They withdraw. They want to avoid scrutiny of their social group. They avoid ostracism. They repair alliances. And prestige relations at the time of depression changed to one of power, not one of prestige. So they're submissive in the power mode. And this is X-polar 4 or bipolar 2 disorder. This is Winston Churchill, not on a good day. This is what he called the black dog. And we again see the timing instability, and we get an overwhelmment of the behavior inhibition system, which I'll show you in the Tesseract again soon. We tend to see in bipolar 2, of course, swings between approach and withdraw mental states, depression and hypomania. And that ambivalence state expressed over a wide span of time appears to occur. And what also tends to occur is this idea of opponent processes, swinging from depression to hypomania. And when mild to moderate, these mood strengths may be adaptive. And we can see Winston on a better day. Now, what I've drawn on a bit today is chaos theory. And so that's called dynamical systems theory. And it utilizes the idea of attractors. Now, maybe all these conditions, psychosis, mania, depression, are states of mind of one substance affected by attractor basins, and maybe not separate diseases. These attractors can be shallow or they can be deep. If they're shallow, they're quite prone to transition from one to the other. But if they're deep, they tend to be quite sticky. Conditions like schizophrenia, you could probably say, as a deep attractor. Now, they're affected by feedback loops. Treatment, maybe we could think of that as being something that stabilizes the attractor and allows the person to come back to a euthymic state of mind. And here is just a graphical. It shows the basin of attraction there and the attractor point at the bottom point of it. So these are states like depression or schizophrenia that a person can fall into. Hypomania would be more shallow and prone to changes, and mania probably is relatively shallow and prone to changes too. So we can talk about high gain mania. Behavioral activation and fight, flight, and freeze system on the Tesseract, both occurring together, leading to a high gain manic state. As I've indicated, that is designated by rage. But probably all it needs is these two other systems to be active under a dysregulated behavioral inhibition system. So that's a high risk approach. And here again is the Tesseract. Can see someone with mania has social dominance leading to the mania and a tendency to power relationships. That may be susceptible to withdrawal states, as in melancholia, the so-called evolutionary freeze. And people who are hypomanic, I think it's quite reasonable to separate these two, that hypomania is a state of activation and seeking, often in a social context, often about lifting self-esteem. But there is a categorical transition people can make between hypomania and mania, where there's dominance. And then we look down here at social divergence, which I've used a synonym of schizotypy. And that past a certain point, it may be that this creative state leads to schizophrenia. Schizophrenia, a deep negative attractor, where there's hypofrontality and withdrawal socially. Are these people depressed? I think we should be asking ourselves that. They may have an atypical depression, by which I mean a depression with retained appetite, retained sleep, sometimes hypersomnia, a leaden feeling in the limbs, rejection sensitivity, which we've talked about with relation to bipolar disorders. Something to think about. And of course, we get trauma-linked fragmentation in schizophrenia. Now, how do you test this model? Well, I didn't have much idea, so I turned to AI. you could identify behavioural and physiological markers. And do they occur with reverted escape, which you could somehow simulate and have subjects involved with that. We could do large longitudinal studies looking at status rejection, and they do tend to precede depressive symptoms. So this research has been done that perceived status and rejection precedes depressive symptoms. We could do fMRI studies of social exclusion, and this has been done, and it's found to coincide with depression and the so-called rumination networks. We could look at social rank gain and see it predicts hypomanic tendency, and that apparently has been done as well. We could look at speech rate, posture, initiative, and risk-taking, and they change with exclusion and inclusion, I should say. And then prestige boosts activate the ventral tegmental area and the approach motivation networks. So prestige does tend to boost them. So just to summarise the talk, and I can go back to any of it as we proceed, I think there is some meaning in psychiatric illness. I think it's a meaning that's been overlooked by mechanisms. We're too enthusiastic or too blinded by discovering a mechanism. It's like sick mitochondria or oxidative stress or insulin resistance, but maybe they're only mechanisms, that the meaning does lie in evolution and reverted escape. And of course I want to find meaning to my own illness. It's something I've dedicated myself to try and understand things. And that meaning, as I've said, is shaped by ancient distal factors, not meaning solely tied to biological proximal phenomena. And I'd like us to get to a unified biocultural account of severe mental illness to involve not only biology, but cultural and social factors as well. And that's it. I'd like to thank Professor Kalpesh Chandrani, the AI I used, my colleagues Dennis O'Loughlin and Professor Richard Newton.
That is a wonderful presentation, James.
I think I went a bit fast.
No, the pace seemed okay to me.
Great.
Yeah. So this was all about the evolutionary aspect of bipolar. Can we say that?
Yeah. And schizophrenia too.
Yeah. So
I mean, because the two conditions share so much in common genetically and on biological markers.
So would you put schizophrenia as well in the same dimension as bipolar?
I think it's a residual category in which the so-called degrees of freedom are lost in a situation and becomes a withdrawal state that it's difficult to get out of. So I do believe it's part of the same spectrum, yes.
Um, well, James, are you satisfied with the DSM-5 system of classification that we have currently?
It has its uses, but I think it's not a spectral system, so I don't think it fully accounts for the disorders we see. I think it's a somewhat phenomena-led um, situation that, yeah, I don't think quite does covers the territory.
I think we had one question from Dr. Jyoti that where do you put personality disorder in your X-polar system of classification?
That's a good question. At level 2, there was the odd kid on the block with the bipolar phenotype and the risk of addiction and depression. So I would see that as the bipolar phenotype, if you like. They can develop syndromes, of course, but they may not. They may just have a personality aberration.
Okay, we have two questions, and both of the questions are similar, so I would club them together. One question is from our senior resident, Dr. Mitesh Rajkot, and one question is from Dr. Bhavya Bhansali, my colleague, third year resident. So both the questions are asking that how do you incorporate this evolutionary aspect of bipolar disorder into clinical practice, and how do you uh, use this knowledge into pharmacotherapy or in treating bipolar disorder?
Hmm. That's a good question. Um, I think it's basically about understanding at this stage. It may be that we do some sort of biological investigation particular to various conditions. Um, so I think often you'll find with bipolar people that episodes have been precipitated by a prestige loss, loss of valuing from members of the group. Um, and I think once you can see that relationship, you can more readily treat them with psychotherapy. And you can understand that as having an evolutionary basis. So yeah, it doesn't really affect pharmacotherapy very much. It's more about the relationship with the patient and sense of synthesis being arrived at.
Good to know that. I think most of the people here in India would think that psychotherapy is not for bipolar disorder. So, what would you say about this, especially by your research and X-Polar and Tesseract? Uh, where do you put psychotherapy in treatment of bipolar disorders?
Um, sure, I mean, it's a very broad category of people uh, who not only broad, but they'll also be in different stages of syndromes at various points. They might be depressed one week and then euthymic a month or 2 months later. And I think the use of psychotherapy is demonstrated that uh, depression can relate to interpersonal psychotherapy, and the cognitive behavior therapists find that it does also. But it's a secondary concern after good pharmacotherapy and a good doctor-patient relationship. So I do think that there is role for psychotherapy. It may often not be dynamic psychotherapy, but certainly working with the patient, finding out where they are and what's troubling them. I think it's therapy really, and it shouldn't be played down.
Certainly, James. We have another question from Dr. Bhavya Bhansali, third-year resident. And it's a long question, so I'll read it out. So you have described the bipolar phenotype as having an evolutionary addiction to the social high or prestige. How do you integrate this into psychotherapy? Do you focus on helping patients detach from their self-esteem from uh, helping detach self-esteem from social rank? And have you found this reduces the striving drive that often triggers manic relapse?
That's a really good question. So it's about uh, what you do with people. Do you have a divorce from your social group, or do you try and reintegrate more? And obviously, they're two extremes, um, both of which can be problematic to be too invested in the group or too separated from the group. I think there is real strides that can be made by assessing self-esteem and assessing how that is linked to the involvement or behaviour of the group. It may not be that you change it, uh, but just it's something you're aware of. Are there other parts to that question?
Let me check, James. Till then, I would also like to highlight to all the members who have joined the Zoom meeting and all the residents sitting here in the department that James himself is suffering from bipolar spectrum illness, and he was diagnosed uh, with the condition when I think you were in Philippines, James.
Yes, I was 19.
You are 19 when you were first diagnosed with bipolar.
Well, it was more a paranoid illness back then. I've had very short and sharp episodes that have alternated between manic or hypomanic. I've had a lot of depression on and off, but I have also had the experience of being paranoid, so I can relate to the reverted escape um, slide I showed you before.
And that is the reason that why you have dedicated your life to bipolar.
Well, I've worked as a general psychiatrist for a number of decades. So it wasn't just bipolar, but I did my PhD on bipolar patients at the service I was working at and did some research with them. Yeah, but you're right. It's a personally motivated thing as well. I really want to uh, get to the nub of what is going on.
I had one more question, James, that we talked about hypomania, and there are certain people, certain psychiatrists who think that hypomania is being productive. So, if you look at the evolutionary aspect of bipolar, then do you think that hypomania has evolved to keep us productive?
I do. That's in at mild to moderate levels. It probably is productive. It's increasing social esteem. Um, and yes, I think it probably is productive.
Then
That's only been looked at by, I think, only one study that found it was productive. Yeah, it hasn't really been measured very well yet.
Okay, then do you think that we should be treating hypomania?
I'm sorry.
Do you think that we should be really treating hypomania?
Uh, I guess it depends on the context, really, doesn't it? What the person is doing. I mean, it's going to come to an end uh, after 9 weeks, anyway, isn't it? That I think we should be assessing people, looking at risks, looking at sexual indiscretions if they're there, and trying to um, guide the person to avoid the excesses that can occur. And at some moderate level, yes, I think it should be treated both as by prophylactic agent or by other medications.
I think we don't have more questions. So I would like to invite our assistant professor, Dr. Kenil sir, to give a vote of thanks.
Thank you, sir, for your time and this wonderful presentation. It helped us to understand the evolutionary aspect of the bipolarity.
I'm I'm very pleased to give the talk, and I thank you very much. I mean, I've got other talks such as more about my own illness and what I went through and what I thought. So yeah, happy to give this talk.
Well, James, I had one more question that you have developed this system of Teseract. So how has been the response from the other psychiatrists in Australia?
Um, well, it's not really properly publicised yet. I've had very good feedback from psychiatrists who have read my book, um, but it's really only a conceptual thing. I think it makes sense to me, and I think it has made sense to a number of my colleagues. Yeah, time will tell.
Sure, I think it's much better than DSM-5.
You might be right there.
Yes. Well, thank you, James, for joining in from Australia. Let me tell you, it's 10:30 there in Australia.
It's what, sorry?
It's 10:30.
Oh, yes.
Yes. So thank you that you have uh, been able to present this lecture at late night from Australia
Okay.
uh, for our convenience. Thank you very much.
Thank you, Divyam. I'll hope to see you again sometime.
Sure, sure. We also have a Google feedback form for our residents and for the people who have joined the Zoom call. So I'll float that in the group, and uh, we'll get the feedback as well from the residents and from the people who have joined the Zoom call. So next time, maybe if we are planning such a lecture, we can improve upon that. Thank you, James.
Great. Thank you.